So we're now going to change gear and move from vaccines to medicines and therapeutics. And I'm delighted to introduce Professor Reecha Sofat, who is a clinical pharmacologist at the University of Liverpool. Her research involves embedding research into routine clinical care with a focus on making and using medicines better. And when we were planning this session, we knew that she would be the perfect person to explain the complexities of medicines data and their availability in the NHS right now. Reecha is Vice President of the British Pharmacological Society and an Associate Director for the British Heart Foundation Data Science Centre, which created the NHS secure data environment described by Rachel Denham earlier on. Reecha, we look forward to your talk.
Great, thank you very much, and thank you for having me here today. And I'm going to split the talk into the two sections, essentially try and explain medicines data in UK electronic health records and try and untangle some of the complexity, but then also focus a little bit on what opportunities that offers for target trial emulation. We've heard a lot about what it's had to offer in the COVID pandemic, but actually should we try and see what can we do beyond that? So COVID was really important for pharmacology and therapeutics because it reminded us that we actually take medicines for granted. So we had a new disease, we didn't have any treatments, and it actually changed society in ways that are immeasurable and continue to do so. So we really do take medicines for granted, and we always forget that. We've already heard from Rachel and from Will about the secure data environments that have been set up, so the National Health Service secure data environment and also Open Safely, and looking at some work from both of those platforms. So just focusing in on medicines data in the NHS, where should medicines data be? So the NHS really is a cradle to grave healthcare system. So when you're born, you register with a GP, healthy registration, and over the course of your life, you may be treated for conditions. You will have blood tests, they will be recorded, linked to your NHS number. You may have risk factors identified which will be actioned. You might get drugs to prevent diseases. You might then have an acute event and go into a secondary care facility, so a hospital or another facility where you will have more investigations, x-rays, more imaging, more drugs, and those will all be linked somehow to your NHS number at some point. And then you will be followed up either in primary or secondary care. And again, all of these data should be linked to your NHS number. And then, of course, your death is registered in the Office of National Statistics, as well as hospital event statistics and other data sets, depending on your place of death. So technically, this should be pretty straightforward. Cradle to grave, NHS number. So is it or isn't it? So medicines data in the UK just made me kind of think about this poem, which most of you will have heard of, the Rime of the Ancient Mariner, where there is water everywhere, but there doesn't seem to be any to drink. And medicines data just kind of is separated in time and across time and across different places. So it's kind of interstellar in its manifestation. So if we just go through where medicines data should be. So in primary care, we have recorded prescribed medicine. So when a primary care physician writes a script and says you should take 5 milligrams of amlodipine once a day for 1 month, and then renews that script. So that's the prescription. That prescription then goes to the pharmacy and the drug is dispensed. So that happens in the UK, and that's a reimbursed system. So those data are collected monthly because the prescriptions can have a charge, but for some individuals, prescription fees are exempt. So actually that cost needs to be recouped. So that's a reimbursement system. So that's how we collect our dispense data. In secondary care, we have inpatient data. So if you're in a ward in a hospital, you will have inpatient care with your regular medicines, as required medicines, and so forth. If you're attending as an outpatient, you may have drugs that are prescribed by a secondary health care provider. And then you will also have general medicines, but also specialist medicines for cancers or for other complex conditions. So when we think about actually where these data are stored, so we've heard quite a lot about the primary care data. So if you think about Open Safely, the providers that feed into the Open Safely platform, EMIS, TPP, and there's a smaller one, Vision, those will all record the prescribed data. The NHS BSA is the Business Service Authority, which collects the monthly data for reimbursement. So those should actually have your dispense data. So then you can begin to do comparisons between prescribed and dispense, which is, how you begin to think about adherence as well. But then the prescribed medicines, you get, if I'm prescribed a medicine today and then a different one tomorrow, you'll be able to see those differences within the prescriptions, but you won't be able to pick that up always in the dispense data, because that will just be a monthly feed. Secondary care gets a bit more complicated. So in hospitals, we call them hospital trusts. So there are about 220 trusts in England, and about 175 of them have electronic systems. The others are still paper-based, okay? So you cannot gather those data from a paper-based system. EPMA just stands for Electronic Prescribed Medicines Administered. And the other thing to notice about EPMA is that it might not capture all of the systems within a hospital. So sometimes cancer systems are different to general systems. So cancer systems will collect the cancer data, drug data, and the other systems will collect the other systems. In outpatients, you may have dispense data which are electronic. They may be captured by the EPMA, they may not be captured. So this is much, much more complex than the primary care systems. And then we have general medicines, which might be captured within EPMA. So if you're on a general ward, you have fluids, you have paracetamol, they might all be captured. But then the real complexity comes when you have specialized medicine. So when you have cancer drugs, they've got a separate system. So it's called SACT, specialized anti-cancer chemotherapy. We've got another system called BlueTech, which captures what Rachel referred to as high-cost drugs. So about 15 years ago, most of the spend for medicines was in primary care, but now it is half and half. So half the spend is in secondary care. And again, this is a mechanism, these databases are a mechanism to understand how this money is spent and where it is being spent. There are other databases for things like intravenous immunoglobulin, which is used as a therapeutic modality. And then there are also disease severity registries, which often don't capture the drug data, but they'll capture the disease severity data, which may not be captured all together in HES and so forth. And then there are also safety databases. So the regulator, the MHRA in the UK, has a yellow card system where patients, physicians, nurses, healthcare providers can actually deposit yellow safety concerns and so forth. So the reporting actually during the vaccine rollout actually became very, very high. But again, these are specialized data, but they're not linked in any way to NHS data. So whilst there's lots of data, actually what the problem is that we don't know where all the medicines data are, and they're not routinely linked to healthcare outcomes. So when we think about how drugs are funded in the UK, I'm not going to go through this slide in detail, but it's there for you to read. But once we begin to think about how drugs are funded, actually that begins to give us clues as to where they might be kept. And then we have to kind of follow the money to actually see where we can then try and find these data sets to then begin to link them. So in terms of moving on to the second part of what we're trying to focus on is then how can this give us an opportunity for target trial emulation? So if we just go back one step, so we spend about 20 billion, actually it's more than 20 billion, on medicines in the UK. And this cost is secondly only to the cost in the NHS of our workforce, but there's no ledger. So we actually don't know if medicines are used as they're intended because they're not routinely linked to health outcomes. So if they were linked to health outcomes, we would be able to understand if they're having the desired effects, the unacceptable effects, but we can also do clinical and cost effectiveness analysis in a much, much more robust way. So some of the opportunities for target trial emulation come from being able to stitch these data together. And what we can be able to begin to think about is comparative efficacy. Can we actually look at risk benefit with drugs that are me toos? So they might be produced by a different manufacturer, but actually they have a very similar effect, but a pharmaceutical company is never going to compare those two drugs, but there may be a rank order. We can look at safety, which is uncommonly an outcome in randomized controlled trials. We can think about repurposing opportunities, but we can also think about how we can use target trial emulation and observational data to feed into living guidelines. And the vaccine effectiveness story tells us a little bit about how we can do that. But actually we can do this across lots of medicines, but we need to move beyond the opportunities given to us by COVID, but actually how do we realize them in reality. So I'm just going to actually skip through these really quickly, just to tell you about some of the examples that we've been working on during COVID, and then what may come later. So these are all examples that are based on primary care dispense data rather than prescribed data. So one of the things that we're interested in is understanding if proton pump inhibitors have antiviral activity. So as many of you know, proton pump inhibitors were blockbuster drugs that reduce gastric acid secretion. They target an ATP pump, but actually they also have an off-target mechanism through another protein, which potentially has a protective effect against viral shedding. So it may be an off-target action of PPIs that may be protective for respiratory viruses across many respiratory viruses. So again, these data sets give us an opportunity to understand, using target trial emulation, whether this is correct. Metformin, a very commonly used drug, which is an anti-diabetic, was actually originally developed many years ago as an anti-influenza drug, and it was actually added to the food of children attending school. And then the glucose lowering effect was actually discovered way after. So we're trying to ask if this is a useful drug for pre-exposure prophylaxis for influenza, COVID-19 or other respiratory viruses. This is how we've begun to use kind of the trial emulation framework to begin to set up the question. And then something else that we've been working on recently is sodium valproate, which is an anti-epileptic drug. So in the UK, there was a report that was published during COVID-19 called the Cumberledge Report that took sodium valproate as an example to demonstrate the harms caused by medicines and where the NHS may be a bit siloed. However, that valproate is supported by good randomized evidence, but anti-epileptics are actually quite difficult to do randomized controlled trials in. And this is work that we've then been able to do within the NHS SD to look at how valproate is distributed across the country. And this is the first time we've been able to do this. But then also this gives us the opportunity to say, well, as dispenses and prescriptions are changing across this population, actually can we begin to use target trial emulation to think about comparative efficacy across different anti-epileptic medications? And I will skip through that. And I'm just going to quickly talk about some of the limitations in terms of using the data. So I think I've already pointed out the data, particularly for medicines, are in different places, and we need to find all of these data and be able to stitch them together and link them to routine healthcare outcomes. We also need to think beyond medicines and healthcare data and think about additional data which can influence the effects of therapy. So if we take diabetes as an example, if I understood what was in the shopping trolley of my diabetic patient, I might actually be able to tailor their therapy in a very different way, which may not require as many drugs, but it gives us a different level of information. And as I've already alluded to, we really need to capitalise on what we've been able to do in the UK over the pandemic and actually use these data beyond COVID-19. So I will stop there. Thank you.